Hello, Hello, good afternoon, everyone. It's wonderful to welcome you to this virtual platform. We are so excited to welcome you here today from wherever you're calling in from in the United States or around the world. I'd love for you to go ahead and pop on into the chat where you're joining us from. This is an exciting group. We meet every single month through a program that's hosted by American International College, AIC, and the OT Echo platform. We have a really exciting speaker today, Cuyler Romeo, who will share a little bit about their practice and their area of expertise. We'll have a mini presentation today for about 30 minutes or so, and then Cuyler will present us with a case study. This is a really awesome time for us to interact and immediately apply what we're learning, and then have the opportunity to discuss. So in about 30 minutes or so, Cuyler, I'll give you about a 5 minutes notice and direct chat. Not that you have to manage that, but I'll give you a little notice. But in about 30 minutes or so, we'll get a case study. We'll break up into breakout rooms with some facilitators, and we'll come back after 15 minutes or so, and Cuyler will lead us in some of those answers and navigating some of those questions with our case today. So again, thank you so much for welcoming us. I encourage you to ask questions in the chat, and we'll monitor that the best that we can. And I also thank you for muting yourself. Questions will be available at the end. Thanks, everybody. Take it away, Cuyler. Welcome.
Okay, thank you so much. Thank you for having me. Just a little housekeeping. I had mentioned earlier, I work with 3 screens. So if I'm looking off to the side, it's not intentional or to disregard anyone's view on the screen. That's just how I can see my notes and make sure everything's running smoothly. My name is Cuyler Romeo. I'm an occupational therapist by trade, clinical trade, and I'm board certified in feeding, eating, and swallowing. I'm also internationally board certified in lactation, and that's my IBCLC. So currently I work in the acute care setting. I'm in a level 4 in ICU here in Tucson, Arizona, sunny Tucson. And I also work in strategic initiatives, so focusing on education, advocacy, research, and family support through the nonprofit Feeding Matters. So I just really appreciate being able to join everyone here today. My passion is getting information out to other OTs that would like to have skill and an understanding of feeding, eating, and swallowing. So today I'll let you read your objectives on your own, but we're going to be discussing the high-risk infant and taking a little bit more of a deeper dive into feeding and suck patterns and how those may impact long-term function. So we're just going to set the stage for understanding pertinent factors that are going to impact your infant's functional outcomes. Our infants are surviving at a younger and younger age when they're delivered preterm. Back when I started in the NICU, I did this as a level 2 rotation as the end of my graduate program. I was, oh gosh, this was 20 years ago, and it was quite unusual for us to have a baby that was under 26 weeks gestation and that was surviving. And I can tell you, we have 4 infants currently that are 23 weeks gestation, and we've even had an infant admitted at 22 weeks gestation. So we're seeing great advances in technology and healthcare. But of course, that's really impacting how these kids are learning how to feed and swallow in the unit and how that's going to impact them when they go home with their families. Feeding is a complex task. It requires the integration, organization of many skills. And I really feel like this is kind of like a surface level statement. When you really dive into the complexity of the feeding pattern and how it develops, it requires every aspect of the brain, as well as physiological stability and organization. The depth of complexity truly is evident when we look at the actual development of the feeding pattern itself. So feeding in the young infant is based on the suck pattern and how that develops in the brain, and is comprised of 2 primary forces at work. So first, I'm just going to orient you to what a typical feeding pattern is, and we're going to take a look at what that looks like on a breastfed infant. The first to develop in the infant is compression. So if you were to put your finger in an infant's mouth and assess non-nutritive suck, and then follow with offering that baby a nipple with flow, you would see a very similar pattern in a young infant. So the first force is compression, and that's the expression or the stripping of the breast or the bottle nipple by the tongue against the hard palate. It's this up and down kind of munching compressive pattern. That action generates positive pressure on the nipple, and then the milk is ejected. A compression-based suck pattern is marked by this rapid and wide jaw excursion, and it can be accompanied by a poor lip seal. A dominant compression pattern can result in inefficient milk expression, but we'll talk about that a little bit more in depth a little later. The second primary component or force at work is suction. Suction corresponds to the negative intraoral pressure that's generated when you have a closure of the nasal passage by the soft palate or the velum, a nice tight lip seal around the breast or the bottle, and then you get jaw depression, which increases intraoral volume and allows the expression or the pull of the bolus from the breast or the bottle nipple. These two components comprise two different types of suck. You have a non-nutritive suck and a nutritive suck, and it is quite critical to be able to identify the differences in these two types of suck as your first line of defense in assessing an infant to see if there is risk or presence of dysfunction. A non-nutritive suck is the type of suck that you're going to see when the infant is sucking on a dry breast or a breast to pacify or an artificial pacifier or nipple. The purpose is not to extract a bolus of milk, but it's just rather to calm and to regulate. And since milk is not being expressed or swallowed, you're going to see a much faster suck frequency of 2 sucks per second. And the jaw excursions will be shorter and faster. So that's that little non-nutritive suck pattern. The nutritive suck, on the other hand, is for the purpose of milk extraction. The infant uses that beautiful, deep, long jaw excursion to generate suction by increasing intraoral pressure, and the liquid is extracted and then swallowed. The swallowing process component results in a nutritive frequency of 1 suck per second rather than 2, because it's followed with that swallow and bolus management. The actual suck pattern references what type of suck the infant is using, how many sucks they're completing in a burst of action before they need to pause and recover their breathing. A mature suck pattern is rhythmical, it's nutritive in nature, and it's well regulated from a respiratory perspective. What you will see with respiratory regulation is that the infant will engage in suck, then the swallow, then the breath, also called the micro breath. Those are sequential in nature: suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe. And then an infant pauses and has respiratory recovery, which is the panting breath, and they breathe, recover, and then they're able to reinitiate and to re-engage. So I want to show you first a video of a functional nutritive suck pattern on the breast. The initiation of a suck pattern differs if the baby is being breastfed versus bottle fed. When a baby first comes onto the breast, they use a non-nutritive suck to stimulate the breast, which sends the signal to the mother's body that there is a baby ready to feed, and that helps with the milk ejection and the milk leg down reflex. So the baby starts with non-nutritive, then we start getting milk flow, and the baby will convert to a beautiful nutritive suck. And that is typically that first latch pattern that you'll see on the breast. Okay, let's take a look. Here we go. The baby has a beautiful seal, completely flush with the breast. A little non-nutritive, shorter jaws, and now we're starting to already deepen. You see the deep jaw excursions? There, there. A few non-nutritive in the middle. But what you can tell from the breast is you will hear the swallow. You'll hear the 1-to-1 ratio of the suck, swallow, breathe. And what you'll see is this prolonged jaw excursion that's occurring with that nutritive draw. So typically babies on the breast, particularly as they're getting started on the pattern, you'll see non-nutritive, non-nutritive, nutritive, non-nutritive, non-nutritive, nutritive. And those can be in a variety of ratios, and that's all within a functional range. Now, this is an infant that is bottle fed. You may see a similar pattern of when the baby first latches to the nipple, being an artificial nipple, even with flow immediately present, they may still start with a non-nutritive suck. They're getting their bearings, they're testing the flow. They'll start with non-nutritive. And as they pull that bolus and fill the oral cavity, which initiates the swallow need, then you'll see them convert to a nutritive suck. This is a 4-month-old infant who has cardiac complications. She's hypoplastic left heart, and she has an alternating pattern as well. So it's a bit more difficult to pick up her nutritive draw. So it's really critical that we have lots of experience watching and feeling an infant pull from the nipple so that you can start to develop that skill set in determining, is it non-nutritive or is it nutritive? So non-nutritive, see that biting?
See, she'll eat as much as you'll feed her.
Non-nutritive, a lot of pursing of the lips. Non-nutritive, there was a nutritive. There's a nutritive. There's a nutritive.
Yeah.
And she's been,
So she's
been
having a hard
gaining
time
weight well and
maintaining an
everything?
oral seal.
Good.
She's
Looks good.
converting back to that lower level of function, which is compression and expression. And I'm working on helping it give her jaw stability, lip seal. I'm also using a technique called negative drawback, where I resist the suck to help her trigger a nutritive draw. And so she's able to engage in non-nutritive as well as nutritive pulls from this bottle nipple. Now, development of this feeding pattern in a preterm infant is uniquely challenged, as they're expected to develop these skills in the external environment before the brain and the body truly has neurodevelopmental maturation and optimization. So in the uterine environment, they're stable, well-regulated, systemically supported. But in the external environment, it's extremely unpredictable, highly variable when it comes into sensory as well as motor and physical experiences, and the brain is easily compromised. So when you look at the brain of these infants, you'll see that 25-week gestation brain is absent of the sulci and the gyri. And that is because the brain is actively and rapidly mapping during this period where they're now in the external environment. So every interaction they have with the environment absolutely changes the mapping of the brain. That feeding pattern is going to be determined by their interactions with us, the external environment. So this is why it's so critical that we provide optimal supports, or the feeding pattern that is actually cortically mapped in the brain will not be functional long-term. Infants that are born prematurely also are at high risk for medical complications, and complications can occur in any of these primary areas: cardiopulmonary, gastrointestinal, infectious, neurologic, obviously congenital anomalies, which may have been leading to that preterm delivery, and of course, development and developmental sequelae. I hope y'all think this is a cute baby, because this is one of my twins. I have identical, there's two of them. I have identical twins. So this is her as a little one. And she is really kind of like that poster child for us to remember typical versus atypical development. And the fact that our premature infants are at a significantly higher risk of developing feeding problems. And they need supports beyond the typical infant in order for them to get to outcomes where they're able to go home and feed safely. Now that we have a little foundation understanding of the subcomponents and the patterns, we're going to use this knowledge to identify how feeding can be negatively impacted by premature delivery. Prematurity can result in deficits in any of these three primary categories. First one is state maintenance, lack of availability for them to learn and to engage in the learning environment. Second, being a structural foundation. They may have impaired strength and function, and this all results in a challenge in the pattern development. And this is where we see suck, swallow, breathe in coordination with all of these unique characteristics or areas of potential deficits that fall under the three main categories. One of the prime takeaways from this slide is that we really need to read them from my viewpoint, would be from left to right. That if we don't first have state maintenance and state regulation, that infant is not neurologically available in order to even engage in developing strength, stamina, feeding skills so that they can have optimal pattern development. So really the first level of intervention is the state maintenance and the lack of availability. We need to work with arousal, regulatory endurance, state regulation, and that ability to engage in reciprocity during feeding before we can consider how we're developing the other systems. So next, I just want to show you a video of how these feeding problems can emerge depending on the acute care setting. This video is from another hospital. It's not from the hospital that I work in, but you'll see some challenges that are often described across units that we see here in the United States. And I'll be interested to hear what others are finding challenge with in their own areas. There's a little one in the NICU. They're using a high flow, fast nipple. The baby's in supine. We're seeing stress signals with the open hand. Baby's biting and compressing on the nipple. That's a reflexive response. Trying to pull off the nipple, but does not have the motoric capacity to respond. Now biting and holding to stop flow and trying to engage in breathing, recovery. That mama is trying to get this baby to eat. And now we have a cough, so we know that for sure we have a penetration or entry into the airway. And you can see this baby's going to go into shutdown. She's retrying despite that response from the baby. Working the nipple in because they're just so, they're so invested in helping their baby eat and need support from us as their team for appropriate approach. Now the baby's trying to push it out. That suck is reflexive. The baby has no choice but to use that suck because of the reflexive response. And so if you look at that as an example, you can see how repeated experiences being offered a bottle nipple in this manner is going to result in that baby developing a compensatory pattern to control the bolus being extracted into the mouth, to control flow. Otherwise, they're going to have complete physiological shutdown. It's clear that our feeding methods and the infant's experience matters throughout the feeding development. Infants are at very high risk for feeding problems, and they require a specialized feeding approach that's tailored to their specific needs. We're learning more about the predictive nature of feeding skill, and we're finding that feeding problems may be predictive of long-term neurodevelopmental outcomes, negative neurodevelopmental outcomes. So the earlier that we can identify the risk factors in the sequelae, the sooner we can establish sound and supportive feeding practices. These infants are at high risk of pediatric feeding disorder. This is a diagnosis that is in the ICD-10 in the United States, but this risk factor applies internationally. Pediatric feeding disorder is impaired oral intake that's not age appropriate, and it's associated with any of these 4 domains. So a nice takeaway is that if you have dysfunction in the medical domain, in the nutrition domain, feeding skill, which is ours, or psychosocial, then you can have carryover a dysfunction into the other domains. Now, feeding assessments are a key tool for early identification. And in this section, I'm going to highlight a few assessments, qualitative and quantitative, and you'll also have a resource share at the end of the presentation so that you can dive into these a bit deeper. We're not getting in depth because of the duration of our talk today. Feeding assessments first starts well before the breast or the bottle is ever offered. It is first focusing on medical stability and prognosis, the feeding skill of the infant, and the caregiver capacity. Feeding exists within a dyad. The difference between feeding and eating is that feeding requires 2 people with skill on both sides. Eating is when somebody has autonomy and the ability to feed themselves and make mealtime decisions. So first, we need to truly look at the caregiver response. This is the most important aspect of assessment and of management. Feeding occurs minimally 8 times a day for a premature or young infant. And so it's during these interactions where they're really going to be developing skill. So what you're looking for is contingent caregiving, looking at how responsive the family is to the cues, how predictable and consistent is their care. There is a qualitative measure that may be of help to you that's called the NEO-EAT, and I will share where you can find that on an open access website a little bit later in the talk. Caregiver-based assessments truly are key to identification of feeding dysfunction, though. It depends on how the parent is feeling when they're feeding and working with their infant. If you would like something that's qualitative, that gives a different angle for assessment and documentation, some good alternatives are the SOFI, the PIBS, which is focusing on breastfeeding, and then the EFS, which is the early feeding scale. I would recommend that if you're in this area of practice, you do a search and you start reading up on some of these other qualitative tools and visit their website to see if it might be a good fit for you. The Feeding Flock is the open access website where these tools can be found. The web address is feedingflockteam.org. All tools are found on this page and they go from 0 to 18 years of age. There are quantitative as well as qualitative tools, and they are focused on caregiver assessment. They also have cut scores, and they are presented in a research version if you're doing clinical research or quality improvement, and they're also presented in a clinical version to be used in your practice. Now, the key takeaway when you're considering feeding assessment and related management methods is the knowledge that we absolutely cannot accelerate the neuromaturational process of an infant learning to eat. The only thing we can do is provide appropriate medical, developmental, and environmental supports so that while they're in that phase of brain mapping, it's optimized. But we cannot speed it up. Force feeding a baby, working the nipple into the mouth, attempting to give more volume will absolutely not speed up your outcome of reaching full volumes or that baby being able to gain weight. It's completely dependent on a top-down approach. It requires neuromaturation for them to be successful with feeding. And then lastly, I'm just going to touch on a few supportive practices that might be helpful as you're diving into your case study. These are the 3 evidence-based intervention approaches that are well supported by the literature. The first is positioning, getting the baby in an optimal position where they can regulate flow, sustain their latch, and be able to communicate to their caregiver. This is looking at alignment and supportive containment. The next is flow regulation. Flow regulation is dependent on positioning. If an infant is being fed in that supine position, like we saw in the NICU video, they really don't have any method of controlling flow other than biting and spitting. So first we need to get the baby into a position where we can hold the bottle level and they can decide when they're ready to suck, when they need to breathe. The 2 key positions for a young infant is either in a sideline position where you can hold the bottle level and the baby can choose when to suck or swallow. Very typical here at the breastfeeding. This is a baby in a cross cradle position and even could be rotated a little bit more further into the body, but in a sideline position, or the baby needs to be well elevated and supported so you can hold the bottle level. Once you tip and dip, the baby has no way of regulating. And then nipple flow regulation, this can be done at the breast or the bottle. That's with nipple selection if you are using an artificial nipple. And we can assist with pumping and positioning to help regulate the flow at the breast and also hand expression. And then the last area of intervention that you may want to investigate more in depth when you have the time is pacing. And that's giving the baby milk flow for a certain number of sucks and then taking away milk flow to ensure that they're recovering their breath. And there's a variety of techniques that are successful with pacing that would be future learning. So key takeaways are alignment from head to hip. Here's that elevated supported position with the baby on the far left. You'll see another elevated position down here with the baby beautifully contained and swaddled, but see how the bottle is level. That's what's key. I also can achieve a level feeding system with elevated sideline position or a cross cradle or football hold at the breast. This level bottle allows flow regulation and it sets you up for pacing. Here's an example of unsupportive positioning. Although the baby is beautifully contained, the baby's in flat supine, and you can see you will get the drips and the flow from that bottle nipple without any active work of the baby's mouth or with the baby being able to regulate the flow. So we're going to kind of roll now into the case discussion and into our breakouts, and I'll let Sarah help us figure out how that's going to work on the platform.
Cuyler, do you have the case study on the slide, or should we bring that up for you?
I can share it on the screen now. Let me pull it over into my screen.
Okay, perfect.
Okay, y'all let me know if you can see it. Can you, let's see.
Yes, if you can just enlarge that for us older-eyed folks.
Can you see that there?
Yes, that's good.
Okay, are we going to go into breakouts or are we going to stay together?
We are going to
actually, oh, sorry. So sorry, we're going to head to the breakout rooms. We have about 15 minutes or so together. We'll be led by facilitators, and then we're going to come on back, Cuyler, and you're going to kind of go through these questions as well, okay, to give your little bit of expertise there, okay?
Wonderful.
Kelsey, do you think you can send us off, or is that me?
I'll do it.
All right, we're going to go ahead and pause the recording, Kate. Our breakout room. Welcome back from your breakout rooms. This breakout with case study is a really unique and innovative portion of the ECHO program. So we hope that you found some nice application in your small groups, and Cuyler will help lead us off with kind of closing us up with these case study questions. Thanks, Cuyler.
Oh, you're welcome. So hopefully everyone had a chance to kind of dive into those questions and discuss SAM. This is a common occurrence and really represents multiple risk factors that we see in families when they're when they're leaving an acute care setting. So this was our little 2-month-old boy that was coming back to us with poor weight gain. We'll start with the first question. What medical factors impacted his ability to learn how to eat? So first I'm going to kick it off to the group and see if you had any thoughts before we chat about it further. Let's see, I'm going to look into the chat, and you can post your ideas in the chat, or you can also come off mute and share directly. What medical factors did you pick up from the case study?
My group mentioned the fact that he was very premature and had bradycardia and apnea as 3 factors.
Mm-hmm. Yes, absolutely. Most of our children that are being born into this type of environment are either premature or they're full term with significant medical complications. So this baby being born at 32 weeks gestation is before the typical week gestation where we see the ability for the baby to engage in oral feeding. Most commonly, infants will start to cue that they have some sort of interest in sucking and swallowing in between 33 and 34 weeks gestation. Neurologically, the baby doesn't have the capacity for any, functional coordination of suck, swallow, breathe until well after the 34th week gestation. But this baby, like you said, was born prematurely at 32 weeks. So we have all that active brain mapping happening before the initiation of oral feeds and throughout the process of oral feeds. Let's kind of jump into the apnea and the bradycardia. If you see, that one emerged a little bit later in his stay, right? We saw those A's and B's they're also called spells, depending on where you're working, start to pop up when that baby was working on oral feeds. This is kind of like the after effect, or it really shows the impact of prematurity and a immature developed brain. So basically the baby doesn't have the the central control for respiration and heart rate regulation. And apnea is defined as the baby going without active respiration for 15 to 20 seconds. But in the acute care setting, we often classify apnea as when they drop below a certain level of oxygen saturation, and that is individual for the baby. And then a bradycardia is when their heart rate is dropping below 100 beats per minute, and often a brady will then trigger the apnea. Yeah, so that's an excellent response there. Any other factors that people identified?
My group did mention the respiratory distress syndrome and the intubation too, and any pain resulting from intubation and extubation.
Yes. When an infant is intubated, then we know that we have basically like pharyngeal arrest as well. And so we can have atrophy of that musculature within the first 24 to 48 hours of intubation. It also is creating risk that you're going to have damage to the structures. Infants that are intubated, extubated, have, that history of multiple intubations, also are at risk of edema, swelling, malasias, and also nerve damage in that area as well. One thing that I just wanted to bring to the surface is that when we're looking at medical complications, kind of span out if you can, and also look at any complications that happened with mom or anyone else in the immediate family. So this mom had high blood pressure that typically causes a prolonged stay for a mother. They often have to go back for multiple doctor's appointments and have that monitored. In the case of a preterm delivery, we usually give magnesium as well, and magnesium or lots of mag on board will delay milk production or milk coming in for the mother. So kind of look at both of those factors since we're talking about the dyad. Any other thoughts before we move on? Okay, let's go to the next question. How would you have supported Sam's mother to help her with her breastfeeding goals?
I can talk about this one. Our group came up with a lot of great recommendations. Our group talked about coaching the mom on pacing and more education on stress signs, providing mom with more psychosocial support, like coping strategies, and perhaps referral to a support group. And Jody mentioned maybe doing like an educational video session to show her about position and other educational factors to let her see what more typical positive experience might look like. And also doing stimulation maybe of the oral muscles prior to feeding. So that was our group.
Excellent. Those are wonderful suggestions. When we look at this question and strategies, it really, it's so shaped by the culture of the unit and as well as the culture of the healthcare system. So in the US, this is quite a large barrier that we have of families not getting the support they need at bedside to be able to provide breast milk and honor their goal to breastfeed before bottles are introduced. And then if we look at other countries where breastfeeding is dominant and formula feeding is either less readily available or it's less culturally acceptable, their breastfeeding rates far exceed the US. What we know about breast milk is that science has never been able to figure out how to reproduce all of the beneficial properties of breast milk. So it really should be introduced to families as medicine. And it's medicine that only a mother can provide. So whether it's 1 ml of breast milk or it's 100 mils of breast milk, it's valuable. It's invaluable to the infant. So it's really kind of like what you were talking about, Kate, starting with that education and the empowerment of the family. What we have found in our unit is that if we can get those babies in skin to skin and on those moms and dads, we have the establishment that they are the primary caregiver. We're giving them a key role in the baby's care, and we are setting ourselves up for more productive conversations, such as breastfeeding and supporting moms in breastfeeding. Many units have, we have a unit or a guideline at our unit where if a mother wants to breastfeed, we are not allowed to introduce a bottle for at least the first week of learning. And even with a guideline in place, that guideline is often overridden because the parent gets very stressed that the baby's not taking enough volume from the breast. And it just really requires so much education on both sides of the fence with the caregivers as well as with the staff in the unit. You as an OT you're in the position to serve as the primary advocate for this area. So sometimes it can feel a little bit isolating that you may be going up against an entire medical team or an uncertain parent, but the care and the support that you provide them really is invaluable. So those are excellent ideas. I agree. It really starts with education and empowerment. Let's move on to the next one. How do you feel like the bottle flow impacted this baby's efficiency and proficiency with feeds? Any ideas on this one?
My group said that the nurse had increased the bottle flow and the baby probably wasn't ready for it.
Yeah, excellent observation. 100%. Antonius, I saw you come off of mute too. Do you have something to share?
Yeah, we discussed that increasing the bottle flow in a struggling to be fed baby, it will be making it like feeling drowning.
Yes, that is often the experience, is that a well-meaning healthcare provider may increase the bottle flow, and a parent may do this as well because they know that baby must hit a certain volume consistently and be able to gain weight in order for them to go home from the hospital. And a key strategy is increasing nipple flow, right? We think that reduces work on the infant. The problem is when we increase flow, when the baby does not have the capacity to manage that bolus within a safe and effective suck, swallow, breathe pattern, they will convert back to a non-nutritive suck. That is their key strategy. Either they'll bite and hold or they convert back to a non-nutritive suck. And then they just are trying to manage flow, just gulping with this non-nutritive pattern, and their little brains do not develop the cortical connections for utilizing a nutritive suck. If we don't get to a nutritive suck, we will lose efficiency. And that's exactly what happened with this little one, is that he never developed a nutritive pattern. And over time, they just need more and more volume with growth, and they cannot get in enough volume using that inefficient non-nutritive suck to support weight gain. And so that's really goes into question number 4 of why did the baby start losing weight? Well, he's now 2 months old, and instead of needing 30 mils, he may need 90 mils in order to gain weight. And it could take him an hour and a half to take in 90 mils using that inefficient non-nutritive pattern. And so then we end up with this high risk of weight loss. So let's kind of just summarize it with question number 5. What did you think were some good strategies for helping this family?
Well, we thought we should first look at the nipple and see if we should decrease the flow rate. We thought doing some pacing education, make sure that we are doing a more lateral position. Try to absolutely do one thing at a time to see if it makes a difference. And I was wondering if talking to the doctor about thickening might be an option to help the baby, but I wasn't sure. So looking for your expertise on that one.
No, those are great suggestions. You're going back to the tried and true evidence-based interventions. The good news is this baby is only 2 months old, so he absolutely can learn and improve. Any infant, I think, can learn and improve. Like, let's not ever underrate their potential. So yes, if we can control the flow, optimize the nipple to be a better match for that bolus regulation, put him in a position where the baby can control it and train the caregivers, this little guy really does have a good shot. And the interim, if you find that he can't get enough to eat in a short period of time, you can continue to look at caloric density. He's already on a 26. That's pretty high. That's pretty high. Usually we don't want to go over a 28, or we get into a lot of GI complications, constipation, and other issues that can impact whether or not a baby wants to eat. But going back to your tried and true, nipple flow, positioning, and pacing are optimal for where you would start. As far as thickening, it just depends on what the root cause is. If the root issue is this baby using a non-nutritive suck because they can't regulate flow in the bolus size, your interventions for positioning, pacing, and flow regulation will cause a significant improvement in function, and thickening may not even be necessary. The other thing to consider is that this baby most likely is weak, has poor nutritive draw. And so if you add a thickened liquid, that baby may be even further stressed and less apt to be able to pull a bolus with something that's high viscosity. So it really goes back to your assessment and getting to the root issue and starting with layering your interventions and seeing what is causing an improvement in function. So those are excellent questions. I know we're down just to our last few minutes. So I want to make sure that you all have your key resources before you leave today. Let me know if you're not able to see my screen.
We can see.
You can? Okay, good. The first one I want to highlight is the Agency for Healthcare Research and Quality. All of these sites are open access. And this is focusing on transitioning newborns from NICU to home. And they have a really lovely toolkit that allows you to do education initiatives as well as quality improvement initiatives that are, best suited for you. The second is the National Perinatal Association's NICU to Home program. This landing page has the published guidelines of how do we help get families home. And then it has key resources in 4 different content areas of basic care, anticipatory guidance, how do we help with a needs assessment, and then how do we help transition home. And it's a really robust resource, and they continue to add new resources periodically. So I always like to go back and check and see what's new. The other is the Developmental Care Standards of Infant in the Intensive Care Unit. This is a very comprehensive set of guidelines that we use in the acute care model, and is a great resource for advocating for families to receive care after discharge. So this is it's quite lengthy. You might want to kind of break it up before you dive into this resource. And then this is the feeding flock. This is your home for feeding assessments that are open access. So I would encourage you to kind of dive into this and see if there's something that speaks to you. I use the EFS as well as the NEO in the NICU myself. And then lastly, I want to orient you to feedingmatters.org. They have a learning library where as a student, everything is free, and families, all of their learning and their websites, all of their modules are completely free to students and families, and they're offered at very low cost. But this is the 6-question screener that you can give to any family to see if that child's at risk of having a feeding disorder. So you can have a more effective conversation with the family as well as their primary care provider. And I use this for absolutely every infant that leaves our unit. And then lastly, if you want a more in-depth learning that's focused on this area of practice, there is a perinatal mental health echo that's offered by Northwest Center. And this is also a wonderful learning pathway if this is something you want to dive into a little bit more deeply. And that is it for me. Thank you very much for listening. You really can change outcomes with these families. Feeding and eating is critical to their development and the parent and caregiver child relationship. So anything that you can do to support these families, we really appreciate.
Well, thank you so much, Cuyler. You are such a great speaker. We really appreciate you coming and volunteering your time and sharing your knowledge. This was fantastic.